Hi everyone, this is Dave Bush. I'm here with a ultrasound video for how to use ultrasound for chest tubes. I wanted to start with a case I had with one of our great APPs this week. I think it highlights a lot of the reasons to use ultrasound when placing chest tubes and for pneumothorax. So we had a 60-year-old male coming in with shortness of breath and chest pain. He had fallen about a month ago and was never seen and had been complaining of like a clicking noise in his chest ever since. He was a guy with unknown cancer and COPD. Didn't seem like he accessed healthcare very often. He came in with normal vital signs. He was noted to be thin, cachectic appearing, had diminished bilateral breath sounds, consistent with COPD. And this is what his initial chest x-ray looked like. And if you can see on this view, this is just the one view obviously, but there's obviously a difference in the right to left chest. He's got a left lower lobe infiltrate behind the heart. And on the right, there's a fairly clear pneumothorax. This is it zoomed up. He has a very clear line here indicating what the radiologist calls a moderate-sized right pneumothorax and a left lobe infiltrate. They say 30 to 50% of the right hemithorax volume. So what do? I say, hey, that's sweet. I get to go jab somebody with pointy things, which is my typical response in this kind of situation. Which brings us to a couple teaching points that I've developed and learned over the years. One is to definitely use caution with folks with advanced COPD. They can have blebs, and just the distorted pulmonary architecture really can lead to false positives, both on chest x-ray and ultrasound. And also, when you're placing a chest tube, it's really nice to use ultrasound just right before you stick the needle in to just make sure that the spot you've chosen actually is still the spot that has the lung down, especially if you're going to use like a needle wire Seldinger technique. The last thing you want to do is take a needle and puncture right into the lung, just because that part of the lung happened to be up at the spot that you'd place the patient in. I mean, you would essentially do the same thing if you were going to do a thoracentesis, right? You would get an ultrasound out and usually mark the spot that has like a nice pocket of fluid. So this is really no different. So I went to this patient, brought the chest tube kit in, explained to him that he had a fairly large pneumothorax on his chest x-ray, and then we were going to put a pigtail catheter in because it had been about a month, and obviously it wasn't getting better. But before I did that, I just pulled out the ultrasound and looked at the right side of his chest in a couple different locations. And this is what I saw. I saw essentially the seashore sign. There you can see up top, you can see the pleural line demarcated here, both on the top of the screen in the B mode, and at the bottom of the screen in M mode. You can see a clear difference between the top third of the screen and the bottom third of the screen. Here's another view, which almost looks like a barcode or a barcode sign. And you can see again the pleural line demarcated real close to the surface there. But the difference in this is that there's a very clean, smooth pattern to the first part of this up top, and then it becomes gritty and rough. And that is consistent with the lung being fully inflated and ruling out pneumothorax. So this confused me, given that he had a fairly clear pneumothorax on his chest x-ray. So I put the needle down and we got a CT, which of course showed no pneumothorax, just advanced emphysema, left lower lobe infiltrate, and really no blebs, nothing else that would necessarily fool us on chest x-ray. So I thought this was an interesting case because I was seconds away from putting a chest tube into a patient with who didn't have a pneumothorax, and without ultrasound, I probably would have wound up on some board panel or in front of somebody else angry at me. And so this was a great teaching case, I thought, to share with the group. I think thinking through this, I do have a couple considerations to kind of go through. So the first thing is obviously, should we just CT chest everybody who's got a pneumothorax before we get a chest tube in? And I think that's okay. I don't think it needs to be done reflexively or as like a hard rule it has to be done. But I think there's a lot of reasons to do it, to figure out underlying pathology, blebs. Pulm will usually get a CT chest at some point with somebody with a spontaneous pneumothorax. So I think it's not unreasonable to do. I think it's a really good idea if it's a smaller sized pneumothorax, or if there's some loculations, if they've got underlying advanced lung disease, if they've had pleural surgery, etc. And that will help guide you if you're still going to place a chest tube, just to know where the spots are that you're going to want to put the tube. Also, considering my case, does this mean that you have to do ultrasound before every chest tube? Well, I would argue no as well here. I think that it's nice to do, and it's nice to have at the bedside when you're doing it to give you that additional confirmation that you're going to put the needle into a spot that definitely has the lung down. But I think there's a lot of situations where we've got really impressive pneumothorax. Everything is fitting with pneumothorax, and it's really not somebody who's got a lot of underlying lung disease, or and it's a fairly straightforward case. And so obviously anybody who's unstable or quasi-stable is not really a great candidate to wait. Obviously, if you've got the ultrasound there, it's a 30-second delay in putting the tube in to just look once with an ultrasound. So I don't think it's a bad idea to do, but I wouldn't say it's necessarily standard of care or mandatory. The last thing I wanted to go through was just if you're going to place a chest tube, the last thing to do when you're looking is just, what are you looking for? On the top of this screen, I see the two ribs, and in between we see the B line or the M mode marker in green, kind of showing me, the spot, maybe needle entry. I've measured the depth of the muscle and the essentially the depth from the skin to the pleura, so that I know how far my needle should be going in before I get into any trouble, because I don't want to really jam that needle in fully because it might hit lung. So I want to go in and measure it, put the needle in about that far, and I should be expecting air return. So that's nice. You can do this statically, so you don't have to necessarily sterilize the probe or put a probe cover on. You can just do this non-sterile, mark out the spot, find your location, and then go through your sterile technique without ultrasound. And that's what I call the static technique. And the last thing is, do this with the ultrasound with the patient in the exact position you're going to do the procedure. And so don't do this with them sitting and then lay them down. Obviously, the lung may change positions when you change their body. And so that's it. I just wanted to go through this cool case I had this week, show some tips and tricks for ultrasound. And if you please reach out to me if you have any questions by really any way. I'm happy to respond and get back to you. Thanks, guys.